I'm Dr. Jam Katari.
And I'm Dr. Sally Moore. And this is a Myeloma Minutes, a podcast for people affected by myeloma, patients, friends and family. This podcast, I don't want to oversell it, but I'm excited about this one because we've got a really dear friend of ours who's joining us today, who's also an absolute expert in her field, and she's going to talk to us about a really interesting and exciting area of myeloma and how we understand it. But before we launch into that, Jam, just what's been going on with you? We always do a little quick update with each other. Are you all right? Life good?
No, it's all good. We were just chatting before we came on about the Nobel Prize, weren't we? And they've just announced some today. The Nobel Prize in Physiology has gone to some work done on T cells, which we've talked about quite a few times. It feels very pertinent. Today on the Myeloma Minutes, we're joined by Dr. Sarah Gooding. Sarah is a Honorary Consultant Haematologist at Oxford and a senior researcher at the Weatherall Institute of Molecular Medicine, also in Oxford. Her work focuses on understanding why myeloma continues to relapse despite major therapeutic advances, and particularly how genetic instability drives drug resistance and disease progression. So normally Sarah is next to me on a Wednesday. She does her clinic next to me. We talk about, is it too early for a cup of tea? How do you fill in this piece of paperwork? My computer's not working. And that's just from me. Sarah actually just asks me sensible questions. Thank you for coming and sharing your expertise with us today. It's really appreciated.
I'm delighted to be here. I've been intrigued as to what you two get up to in this podcast studio, so I'm here to find out.
Excellent feedback. Very welcome, Sarah. We say that all the time, but let us know. Well, where should we start, Sarah? Because your expertise is broad, isn't it, really? Not only are you a doctor who works alongside or used to work alongside me and now Jam in the myeloma clinic, but also you do extensive research with colleagues at the University of Oxford. But we don't really want to focus so much on your research, although it is totally fascinating. But I guess what we really want to speak to you about is myeloma risk and how you understand it, and maybe even how you explain it to patients. This is quite a complex area, and both Jam and I have heard you talk on many occasions, and we think you have a gift for simplifying incredibly complex ideas.
So if we go back to the beginning, and we will diagnose the myeloma, we'll look at the myeloma cells under the microscope, look at the different types of proteins that the myeloma cells express. But a key test is what we say that the genetics, understanding what the genetics of the myeloma is. So if we can just break that down, Sarah, genetics in itself, we all have genes, but we're talking about the genetics of the cancer. Can you just sort of break that down, and what does it mean, and what are we trying to understand?
So I think the first thing to say about myeloma genetics, or indeed the genetics of any cancer cells and of any type of cancer, is that we're not, in the vast majority of cases, and not with myeloma, we are not talking about genetics you've inherited from your parents. We're talking about the genetic changes that are only in the cancer cells and not in the healthy cells of your body. It is one of the defining features of cancer that there are things that have gone wrong in the genetics of the cells which has made them turn cancerous, in the DNA. One of the ways that we try and understand where that cancer's come from, what it's going to do next, is by looking at the errors in those cancer cells. And that is a very broad principle. Over the years, we've begun to understand more and more that this is really important in myeloma cells, in understanding the different subtypes of myeloma and the different ways that myeloma may go on to behave, how it might respond to the treatments you get, and how aggressively it's going to sort of come and go through with different treatments that you may have in the future.
So not all patients with myeloma will have the same genetic changes, because I think we've all had a number of patients come to us and say, well, we've all got myeloma, so the changes in this cancer are the same in me as they are in everyone. That's not the case.
Absolutely not. No. You could take 5 people with myeloma and they would all have completely different genetic changes. But what's really interesting is that those genetic changes have come from different parts of the genome. That's all the DNA that you have in the cells of your body. But they've ended up causing the same thing, which is to cause the same cancer in that person's bone marrow. Myeloma is very variable. The genetic changes that can cause it to happen, there are some things that we do see again and again, but not in everybody. There's, for example, some things that happen in 20% of patients, other things that happen in 40% of patients, but they're all, mixed together. And any one person might have a set of 10 things, but they might be a different 10 things to somebody else.
So, Sarah, it's really interesting because I often say to people when I see them in clinic that there's nothing you've done to deserve this. And I guess the fact that this doesn't run in families also shows there's no familial genetic component to it. But I also say myeloma is different in everybody in terms of how it behaves and how it presents. And do you think there's a link there? First of all, would you agree with that statement that it's different in everybody? And then do you think that might relate to the genetics that you're an expert in, or is that yet to be explored and totally understood?
Well, it's certainly not totally understood, but we have made huge progress. Well, gradually over time, but particularly in the last 10 years when we've been able to do things like whole genome sequencing, for example, or more molecular tests that enable us to understand so much more about cancer cells in individuals. Over this time, we've really increased our understanding of the different things that go wrong in myeloma. And it is certainly true that there are some genetic changes that we do see crop up, groups of patients that we are beginning to understand have implications for that myeloma. We talk about risk here. So there are some genetic changes in the DNA of the myeloma cells, which we call high risk, which means they might cause more trouble. And there are others that we call standard risk, which means that they're more the sorts of things that are generalizable across myeloma in that they don't have particular implications one way or the other.
Practically speaking, Sarah, at diagnosis, we do these genetic tests. Now, there are a number of different techniques. In a UK audience, we do a test called FISH, and these results are often back within 3 to 4 weeks. We generally recommend that at diagnosis, certainly all patients has this testing done. We think it's extremely important. So, Sarah, you mentioned these different sort of groups of patients, standard risk and high risk. At diagnosis, what is the spread of different groups of patients, and what does it mean for how, for example, they might do on treatment?
We expect that around 20% of patients will have what we call high-risk genetics. When we do that test called myeloma FISH, which is looking at some of the genetic changes on the myeloma cells that we find in the bone marrow when we do that bone marrow biopsy. The myeloma FISH test looks at around 5 different genetic changes. And from those tests, we think we will identify around 20% of people as having high-risk changes. But actually, that's just a top-layer answer. You can go into more and more layers of complexity about that, which we probably won't be doing today, because different combinations of things might give you different levels of risk, some of which might be even more high risk than high risk, and some of them might be only just high risk, and some of them might be even better risk than standard risk. So, we have to hold ourselves back from becoming overcomplicated about this, I think. And it's only by looking at huge groups of patients through really big clinical data sets that you can begin to really dig into some of those more subtle things. And that's not really so relevant, I think, when you're talking to one person in clinic who's just had a diagnosis of myeloma. That's all a bit academic, isn't it? What they really want to know is, how does this affect me and how my myeloma is going to behave? So I think we have to reel it right back in and take this into a really personal question as to, does this change the treatment I should have, or does it change any of the ways I might respond to these treatments? That's not just about the genetics, that's about all sorts of other things as well, to do with how fit someone is, or how old they are, or the sort of treatment that they can tolerate. So there's loads of different things that come into these conversations.
I think the way you've described it is more of a spectrum rather than people absolutely fitting into one group or another. Have I understood that correctly?
This is interesting, isn't it? Because, for example, if we were running a clinical trial and we wanted to decide who we were going to recruit into the clinical trial, spectrums aren't very helpful. We have to be quite clear about categories, because you need to define specific groups of people if you're going to recruit only one of those groups into a clinical trial. So if, for example, we thought we should do a clinical trial just into high-risk myeloma, we would need to be very precise in how we define that, and we'd need cutoffs in the myeloma research community, and in clinical trials that is exactly what we have to do. We have to define what we consider to be high-risk myeloma, and we do that mainly through the genetic changes in the myeloma cells, and a few other things as well to do with how much myeloma somebody might have on board when they're diagnosed. There's always more complexity beneath those basic categories that I think is maybe more relevant when you're talking to somebody one-to-one.
So my follow-on question then, in terms of, the sort of categorization, is how does the genetic risk that you've described tie in with what we understand as a staging, the ISS or the RISS? There's been numerous iterations and variations of that. So is this separate? Because people often say in clinic, don't they, which stage am I? And I always say, well, this isn't like having a solid tumour. It's not like it's spread anywhere. And so the same rules don't really apply. But nonetheless, somehow it appears that the genetic risk sits slightly outside the staging. Could you talk us through that?
I think this is a really complicated area, and the reason it's complicated is because science and understanding progresses. The way that doctors use to classify different myelomas, and we do love to classify things, don't we, lags a little bit behind the science. Back before we were used to using genetic tests at all in myeloma, we had this thing called the international staging system, which was really just a reflection of how much myeloma somebody had in their body when they were diagnosed. So it used blood tests that kind of reflected that. And then a while after that, we started to introduce these tests that are done in myeloma fish, which is something we've mentioned already. That's the genetic test we do in the UK. And then we had this thing called the revised international staging system, which took some of those fish tests into account, identified that some of those made you maybe a bit more high risk, depending on whether you had those genetic changes or not. And then this year, we've had another leap forward again, because the organisation that is the international body that makes these decisions on behalf of all of us, which is called the International Myeloma Working Group, have published yet another new way to define risk in myeloma. So we've got to now get our heads around this new system. And it builds on what we've been doing before, but it's just a little bit more refined in the way it decides and it defines what high-risk myeloma is.
Part of the reason why there has been this continual change is that treatments have got a lot better. So, as you said, with the original iteration, the ISS, like people would have a very high stage, or 3 is the highest stage. If their kidneys weren't working properly, essentially you'd be stage 3, and that was always a bad prognostic indicator. But now, thankfully, we're much better at improving kidney function much more quickly, and it's less irreversible, which means that number in itself has less relevance. And as new treatments have been developed, what is high risk is continually changing. So we do have to be on our toes. I mean, it's an emotive term, isn't it? High risk. And Sally, you mentioned how, it is something that we have to talk about in clinic. And I'd just be interested to know how you sort of broach that topic. And Sarah, you touched on such important themes, is that the genetics are one sort of point in a number of other factors that may determine how treatment goes.
Yeah, so it's absolutely brilliant that we have so many more treatments now, and that has made these things so much more nuanced, because back when we were medical students, there was so little on offer to treat myeloma that actually how much damage that myeloma had done when you were first diagnosed was the main kind of defining factor about how well you'd do. Whereas now we would absolutely expect to get rid of all the myeloma that we can possibly detect in the body with that first line of treatment, with induction therapy. So actually what we're looking at now isn't really saying, can we get rid of the disease or not in the first instant? Because we're pretty confident that with most people we can. What we're really trying to dig into with new risk status definitions is, how's this myeloma going to be behaving in 5 or 10 years' time? How's it going to cope when it's been exposed to maintenance treatment for 3, 4, 5 years? Is it the sort of myeloma that will learn how to become resistant to that maintenance treatment? And if so, is it going to come back a bit sooner than other myelomas which might not be so good at becoming resistant? Therefore, we need to use measures of risk that aren't so much about how much myeloma you have when you're first diagnosed, but what is the biology in those cancer cells that is going to make it behave in a certain way when we expose it to all these great drugs that we now have. And that, to me as a scientist, that's really interesting, but it's also really important, because what we're aiming for is to be able to give people a combination of treatments that will be the trickiest we can possibly give to the myeloma that person's got. We want to give treatments, firstly, that are tolerable, but also that are going to keep that myeloma away for as long as possible. And that is going to need personalisation. And that's where we're all heading, to give you the right treatments for your disease.
Sarah, it's so interesting to talk to you about this and how you may discuss it and how you think about it, particularly from that scientific perspective, which is clearly an amazing marriage with your clinical perspective. I guess when I talk to people, and I'm going to be very honest here with our listeners and with you both, when I talk to people about risk, I want to share the information I have with them about their disease. I think it's really important that they are cited on that. It's their body, it's their life. But then when genetic changes are apparent and they may suggest that person has a potentially shorter time in remission, for example, because the genetic changes look concerning, I might try and soften the blow a little bit by saying the treatment's still going to work. We'll just monitor you more closely and the disease may come back sooner, but there are other treatments we can offer you. And I guess I do that, hands on heart with the very best intention. But I think what's sometimes forgotten is that we see people in clinic equally who don't have any genetic changes. We think are going to do really well and they don't turn out to do as well as we'd like. And so I guess the reason I'm mentioning that is to say that this is a delicate conversation because there is so much nuance and we don't have all the answers and the answers are continuing to evolve. And even though we might suggest something in clinic, we don't necessarily get it right. In fact, we frequently don't get it right.
I totally agree, Sally. And the genetics are one piece of the puzzle. Sometimes we see people, you mentioned that sometimes people have no genetic changes, but they might relapse very quickly after a stem cell transplant, for example, maybe after 9 months to a year, and you didn't see it coming. Recently, I've looked after someone who had a very stable genetic standard risk profile. And I was so confident that actually things were going to go very well, and they haven't gone as well as we'd like. And that's why I think pulling all the bits of information that we have together and continually reassessing is very important. Sarah, you touched on personalization, and we talked about high risk and what that might mean potentially in terms of what you may do for certain types of treatment. But for people now with very standard risk disease, I do think we are entering an era when we are confident that they have what I call genetically very stable myeloma, that we can start to shorten the amount of treatment that we're actually giving them. Maybe it feels like for certain groups of patients, we're now over-treating some people who have the more sort of standard risk genetic features and they do well, and maybe certain higher risk groups, of which cytogenetics are one part of them, we can't quite treat them in the way that we wish to.
What we want is to give just enough but not too much treatment to everybody and to give them the right treatment. And personalisation isn't just about identifying the people who will do less well, it's also about identifying the people who will do really well, and we want to give them the absolute least amount of toxic drugs that we can get away with giving them. Yeah, that's an excellent point. But I also think it puts the pressure on us to keep developing better tests. We've been doing myeloma FISH now for a long time, over 10 years. We need better tests. And that's one of the things that is changing internationally and in the UK. And it's not just about genetics, it's about all sorts of things to refine more information about individual people's myelomas and how they might behave. Within the myeloma research community internationally, finding better tests to tell us more information is a really important focus. We call it biomarker discovery. More and more discovery of tests you can do that help you look after people as well as you can.
Sarah, you mentioned that FISH is quite old now, and actually in Oxford and for our surrounding region, you've been developing a sort of more detailed analysis, the myeloma gene panel. Can you tell us a little bit about this actually?
Again, this is something that's been happening around the world. Different groups of scientists and doctors have been gathering data to identify far more about the genetic changes that happen in myeloma cells that you can tell just by this myeloma FISH test that we've mentioned a few times. With the introduction of genome sequencing, into science more generally in the past few decades, this has gradually become something that has become much more easy to use within clinical laboratories. And therefore, we can use genetic sequencing to identify far more about the genetic changes in all sorts of different cancers, not just myeloma, than the tests that we've been using historically up till now. So something that in the UK is done really well is innovation in using genetic tests in the clinic. So, for example, we're much better at diagnosing the causes of things that are wrong across diseases that are very widespread, whether those are things that are inherited, that babies have or children have, or whether these are things that are to do with cancers or a whole range of stuff. Myeloma is no different to that. We've been working with partners in the US to develop and introduce into the clinic this test that we call the Myeloma Genome Panel, where we take particular parts of the DNA that we know are particularly affected in myeloma, and we sequence them really deeply to find out what the changes are. But using this, we can do a test that is much more detailed than the FISH that we've been doing up till now.
It's hard, isn't it, all the lingo that we use, but what exactly is sequencing? I think you mentioned earlier as well, whole genome sequencing, because this is scientific terminology, isn't it? So could you just unmask that for us?
We all inherit DNA from our parents. We've talked about that already, and that it's not that inheritance that causes people to get myeloma, but the DNA within the cancer cells will be carrying a whole load of changes, mutations, bits of chromosomes that are stuck together in the wrong way. And that is something that's just happened over time as the cancer has evolved inside somebody's bone marrow. It is now remarkably quick and easy and not that expensive to actually sequence the DNA in those cancer cells. Now, this is going again a little bit into science and biology, so apologies to people who don't enjoy that. But, our DNA is made up of a sequence of 4 bases and a bit like computer code that can be identified, and what's different, your normal healthy DNA and all your other cells can be identified. And that's something that we can now do extremely easy in the laboratory for a few £100 per patient. And what we are trying to do is to bring that in to make that a routine NHS test that we can deliver just as easily as we would deliver the FISH test we do now.
So if we were to talk about that in sort of more day-to-day terms, do you think it'd be fair to say that you're sort of reading your genetic makeup of the myeloma cells? Is that another way of explaining it, perhaps? Or am I oversimplifying it a bit there? It does sound a bit like that, doesn't it? We're trying to figure out where the spelling mistakes are almost, and the dodgy spelling is where the trouble may lie. Is that a bit, am I oversimplifying that?
No, you're not. That's a really good way of explaining it, Sally. But it's not just spelling mistakes. Sometimes the whole sentence is back to front, or a paragraph might be missing, or it might be duplicated.
Sounds like this podcast, to be honest, but...
No comment.
That's a really helpful analogy, guys. But Sarah, that's honestly fantastic work. Hopefully we can see a future where people are getting much more personalized information on the behavior of their myeloma. So maybe we're going to be moving away from talking about this is standard risk, this is high risk, sort of in a very categorized way. And we have a much more dynamic and detailed information guide that sort of moves with the patient as they sort of go with their journey from myeloma. Because Sarah, I know you feel about this very passionately. It's like nearly every day we're talking about a new drug. I know you love the new drugs and it's great and it makes such a difference, but sometimes it feels that diagnostics just doesn't get a chance to keep up or is funded in the same way to mean that we can get the most out of these drugs.
Well, the two have to be developed together, don't they? And it's all very well having all the drugs at our disposal, but we have to decide the best way to use them. And one of the things that's very frustrating, and I'm sure you two agree, is that you don't necessarily know which drug's going to be best for somebody, which one might give them horrible toxicities versus which one might be really brilliant because it'll put their myeloma into remission extremely easily. Historically, we've ended up having to treat somebody with a drug for several months before we can say, you know what, this one's not working. That 3 months has been wasted, but instead the person has had to put up with some side effects. The patient's had a horrible time because they've had side effects for no benefit. The healthcare system has spent money on something that shouldn't have had money spent on it because it didn't work in the first place. And, time and quality of life has been lost. So I guess what we're all really aiming for is to get rid of situations like that and trying to have a bit more certainty that this drug will be the right one for somebody up front. And I'll give a really simple example of how you might do that. Many of our drugs require one particular protein to be on a cancer cell surface in order to work. T-cell therapies or CAR T therapies in myeloma are a classic example of that. They bind to one particular thing on the myeloma cell membrane, and if that thing isn't there, they're not going to work. Now, one of the things we can do with our genetic testing that we've been discussing is to see if that gene that makes that marker that the drug needs is still working. And if that gene has been lost or damaged, well, then the drug's not going to work. because the protein that the drug needs to bind to isn't going to be there. And that's so simple when you think about it. But, as people have had myeloma for many years and that cancer's changed and it's evolved and it's become drug resistant and it's been exposed to this and it's been exposed to that, actually being able to stop and check if the protein you're trying to target is even still there is a simple test which could save a huge amount of time and unpleasantness potentially if you're going onto a drug that doesn't work for the patient. So I'm pretty convinced that that would be money well spent to do a test like that to see if you could determine whether the drug might work or not.
So we can hear, your determination, your passion as you were talking about that there, and it makes perfect sense. And I suspect our listeners will be thinking, well, yeah, obviously, why would you put me or my loved one through this? The science is out there to answer those questions. So why on earth aren't we doing it? And I guess maybe that's all to do with funding and understanding the science in more detail. And it's a whole complex infrastructure, but it seems so obvious, doesn't it? Of course we should do that. I guess that's the research you're doing in Oxford, isn't it?
Well, it's not just research. Bringing a new test into the infrastructure of a healthcare system is a really big thing. And this is something I am learning about, believe you me. But you have to prove that the test is extremely reliable and robust, because the last thing you want to do is to start using a test which isn't sensitive enough, isn't accurate enough, isn't precise enough. And it's all very well doing something in the research laboratory, but the standard that test has to reach in order to be relied upon by patients for decision making about their care, that's a whole nother level. And we've got to be absolutely sure that any new test we develop is extremely safe and robust in the information it gives before we can use it to make decisions.
Absolutely. Well said. If we go back to our patient, he or she has had the cytogenetics tested. We recommend that everyone get cytogenetics done at diagnosis. As people go through lines of treatments, we often repeat bone marrow biopsies. Sarah, would you recommend that cytogenetic testing is redone each time someone has a bone marrow before they're going to start a new treatment? Does it give us sort of useful information?
With a kind of purist hat on, I would say absolutely yes. We should be getting as much genetic information as we possibly can every time we're making a new treatment decision. But in reality, it's not quite that simple, because nobody loves a bone marrow biopsy. No one would choose to spend their morning having a bone marrow biopsy. And so there is a little bit of a weighing up to be done as to how willing somebody may be to have that biopsy done, which can be painful and isn't a fun thing to go through necessarily. So it does at the moment require a bone marrow biopsy to get this genetic information. And you have to have enough myeloma in your bone marrow that we can get out of that biopsy sample to be able to get the genetic information from it. So there's no point in doing it too early. You've got to expect to have a certain amount of the myeloma in there. What would be absolutely brilliant, and what many scientists in the world are trying to aim for, is that we can get the same genetic information from a blood test by really sensitive analysis of tiny pieces of the myeloma, or any other cancer for that matter, DNA that's floating around in your bloodstream. But you're going to need to watch this space for a few more years, I think, before that sort of a test is ready for the mainstream in myeloma. But people are trying to do that. What we do know is that the genetic information in somebody's myeloma can change over time. So stuff that has gone wrong isn't going to right itself necessarily, but more things can emerge, whether that's because things are changing all the time, or whether that's just because particular genetic changes that you didn't discover last time because they were lurking in only a tiny fraction of the cells. And then they have an advantage, so they grow more than some of the other bits, and then you didn't discover them when you couldn't see them before. Who knows? But the important thing is that we know from the research we've done that when we do bone marrow biopsies, every time somebody has a relapse of their myeloma, we do discover things we didn't know about before. And sometimes those things are high risk things. So it may be that somebody is standard risk when they're diagnosed, and they may have a few more relapses over, 10 years or more. And by the time they've had a few different types of myeloma treatment, we may be able to see some high risk things in their myeloma genetics that weren't there before. And that might change the way we want to treat them we may also see some things that indicate drug resistance to particular types of drug. And then we know there's no point in giving people that drug again because the genetics show that they're not going to respond to it.
So I think that's so interesting, Sarah, and I think that speaks to a few of our previous podcasts, because I think it's fair to say that the general understanding of myeloma up until recently is, as you go through your different types of treatments, the time to which you relapse or the length of response tends to generally get shorter. But I think some of the newer drugs that have come through have sort of turned that on the head, haven't they? Some of the newer drugs offer the promise, the potential of actually saying, even if your myeloma has changed, and even if things look like they might be harder to treat, maybe these newer drugs will actually do a pretty good job of controlling the myeloma. And I think, that perhaps speaks to how much the field has evolved. And it is that marriage between the clinical and the science and the pharmaceutical industry as well, really pushing this field forward to hopefully provide a better outcome for our patients. But I don't know if you would agree with that statement. It's a real sort of overview, isn't it, really, of our pathway at the moment. But if there is any truth in that, I certainly hope that continues.
Yeah, so do I, Sally. I think what we would like to do is identify the treatments that are best and most effective for high-risk myeloma. Use those as soon as we can. That would be great. So some of the newer immunotherapies like CAR T cells and T cell engagers, we're only really beginning to use those in earlier lines of therapy, but early evidence is suggesting that these might be incredibly powerful treatments for what we've traditionally seen as high-risk myeloma, and they're going to have the best chance of working. So whereas historically we've been saving them for later because they're new and we haven't quite known enough about what they're going to be like in earlier lines of treatment, I think the direction of travel is very much that when people at the beginning have these high-risk markers, that we should be using our newest and most powerful treatments then to give them that long remission at the beginning and really suppress those tricky high-risk clones that we know are in there.
It just comes back to sometimes we don't feel like we have all the tools we want to treat high-risk myeloma as effectively as we need to. And we almost have too many drugs in a way for genetically very stable myeloma, and we're trying to work out how to minimize toxicity and stop treatment. So we just need to use this better understanding of what you've been so eloquently telling us about to try and personalize that experience more.
Yeah, and there's some great trials that have been done in the UK and are still going on, really digging into this question. So a few years ago, we had a trial called the Optimum study, which was about identifying high-risk myeloma and giving it much more intensive treatment. There was a really very clear message from the outcomes in that trial that if you treat high-risk myeloma more aggressively with more drugs, those people do better. That's been a very, very important learning point for us as a myeloma community. So it's really important for us as myeloma doctors and patients to lobby to try and encourage the way that our drugs are funded in this country to enable us to give those people with the highest risk myeloma these more intensive treatments. But now we're moving on to saying, well, the Optimum study used drugs that we're already using in myeloma, but we've got these new treatments as well. We've got, bispecific antibodies, we've got CAR T cells. What about those? Let's try those in high-risk myeloma. The studies we should be developing now should be bringing those drugs into this group of patients who have high-risk disease and trying to test whether those are the things we should be using first off. And I hope that that's where we're going to be going. We've also got the RADAR study, which is about to finish recruitment in the UK. And again, that is a study that uses both genetics and how patients respond to treatment during the first few cycles of treatment to either intensify or de-intensify treatment based on that risk. And again, that's going to be a really important study for us to see the readout over coming years.
So a really big shout out then for clinical studies and actually participating in them, hopefully from a patient perspective, in terms of you not only does a wider community benefit from the learning, but hopefully the patient who's enrolled into that study, like the Optimum study, had a better outcome. So that's really exciting, isn't it? And we know that our patients may be approached time and again in clinics, certainly in Oxford and where I am in Bristol, about participating in clinical studies to address just these questions. So yeah, great stuff, Sarah. It's exciting, isn't it? It's exciting from a scientific perspective. And I hope for our listeners, it certainly gives hope that the future is looking brighter almost year by year as we understand more about the disease and the treatments.
So talking about the future, Sarah, if we go to 2050, then hopefully we'll all be retired by then. I'm hoping I will be anyway. So if you're diagnosed with myeloma in 2050, you will have some very advanced molecular and genetic tests. Will that then give you a sort of a menu, a bespoke treatment that can offer you a limited duration, non-toxic treatment that can cure your myeloma in one go?
I hope so. I mean, that's what we're aiming for, isn't it? And then a really easy blood test that you could have every few months that wasn't very traumatic, that would be incredibly sensitive to tell if that myeloma was beginning to come back, with a clear decision path of what to do about it if it did.
We need to reconvene, don't we, when that day comes and celebrate. I'm not quite sure how, with a special celebratory podcast, perhaps. Yeah, and let's wait for that to happen.
Sarah, thanks so much for your time this evening. It's been a fascinating discussion, and we'd love to get you back on in the future to talk further about a lot of these interesting areas that we've touched on tonight.
Yeah, Sarah, you're a whiz and an inspiration. Thank you so much for sparing your time.
I've really enjoyed talking to you. Thanks for having me.
This has been the Myeloma Minutes. We hope that you found today's pod engaging, interesting, and above all, useful and understandable. Please remember that this does not constitute medical advice. Thank you so much for listening. Please do feedback on what you've enjoyed and what you'd like more of. You can email us at themyelomaminutes@gmail.com, and we'll see you at the next one. Bye.